We talked a little bit about signs of different moles, right? I want to start by talking about basal cell carcinomas. I think I mentioned last time they're the most common type of skin cancer that exists. They have very characteristic of them pathologically that you can pick up with your eyes, and there's definitely different subtypes, and those subtypes are very important in determining treatment.
Yes.
So you not just pay attention to the fact that they're basal cells, because not every basal cell carcinoma is the same. Nodular superficial basal cell carcinoma is going to probably be there for a really long time. It's slow growing, won't break off and kill you. And then you will have something more of an infiltrative nature that has little tentacles under the skin.
Or tree roots. I call them tree roots.
They're little tree roots. So whatever you see on the surface might just be the tip of the iceberg. And sometimes patients are very discouraged when it starts off with a tiny little dot and then they end up with a big surgical defect.
That's the size of a $50.
Right, because that infiltrative nature, just think about those little roots or branches. Those branches are very difficult to see with the naked eye. These are microscopic extensions of the cancer underneath the skin. So I guess the point there is you're going to see something different and abnormal. They tend to be red, raised, pearly in nature, or they'll become an ulceration.
And they're bleeding on you every single day without even touching it.
Yeah. Like men say, I'm shaving.
Yep.
And it always bleeds. I've had a few of those. It eats away at tissue. That's what basal cell carcinoma in the advanced stage will do. Mm-hmm. So they'll create wounds that don't heal. So you got to pay attention to any non-healing wounds. Colloquially, we call those rodent ulcers. So if you think about that, it's pretty graphic.
Yep.
And it can look that way. And anything that you leave unchecked can definitely become a big problem.
And eat away where it is.
Eat away at tissues, exposed structures underneath. Mm-hmm. And if they outgrow their blood supply, then they can go necrotic, meaning the tissues will die. And patients will come in with maggots, foul odor ulcers. I mean, all sorts of different things.
Exposed bone,
muscle. So in the advanced stages, it can be pretty severe and require a lot of treatment.
Now, squamous cell, that will be our second one.
Right.
Definitely comes in different stages too. Like we talked about, cutaneous horn can be seen. It's definitely, some people confuse it for a wart. They'll come in and say, I've had this wart and it's been hanging on my ear and stuff like that. But they have a distinct kind of tell to them. Other places that we talked about, the keratoacanthomas, those are massive little spots that pop up really quickly. I usually tell my patients within the time frame of 4 to 6 weeks, the size of a nickel place has popped up. They kind of look like volcanoes erupting.
Yes, that's a great description of them.
Definitely kind of ulcerated at the top, but definitely something you need to worry about because those tend to eat down a little bit further than basal cell and they can metastasize pretty quick if left untreated.
And sometimes they spontaneously regress.
Yes.
Meaning they'll go really quickly and then they'll kind of
the
take
body will
themselves
start
back.
trying to treat them and then they'll still be there a little bit.
Yeah, and people will say, oh, it's gone now, I don't have to worry about it, but the part underneath the skin is still there and that still needs to be treated.
And something we didn't talk about last time was actinic keratosis.
Yes,
they're precursors to squam. Not everyone will turn into a squamous cell carcinoma. I usually say about 1 in 4 you would expect to change at some point. But they turn into that early squamous cell in situ, which is very, very easily treated if you catch that at that stage because it's in situ means in place. It hasn't passed that skin barrier and
right. That was patient stage 0.
Yes.
Yeah. If it hasn't broken the surface, it can't go places.
Correct.
Yeah. So all the in situ cancers, which we use for squamous cell and for melanoma, tend to be the ones that I tell everybody, like, it's contained inside your house. Like, you don't have a roof leak. You don't have breaks in your windows. Like, it's still cutely contained in your house. So you're not, if you surgically treated or you treat it in some of the other modalities we're going to talk about, then it doesn't have a chance to escape and go places, which is what we want. We want to get cancers treated as early as possible.
And a lot of those superficial ones you're able to treat with easier treatments, I say, versus being kind of on surgery without surgery, kind of. So even like topical chemotherapy creams that kind of rejuvenate the skin, I say, what it does is it basically sheds those layers, trying to get rid of all the abnormal cells so new cells can form. But that can be over several weeks of at-home treatment. If you have a lot of abnormal cells around there, like precancers, patients kind of get upset because they're like, my arm is on fire.
Yeah.
But it works.
Right. I'm going to try to break it down a little bit, like systematically about how, at least I think of it, and I think most of my colleagues think about how we approach cancer in the skin, right? So if we get something in the early stages, like an actinic keratosis,
right,
you can treat it with just cryotherapy. It's one of the most common things that we do, is that liquid nitrogen that makes it burn.
-320 degrees.
Yes.
It's colder than dry ice.
It is colder than dry ice. It does cause a burn.
Yes, first degree burn, basically,
Yeah,
with a
pretty
blister.
much. And it can blister. It can be red. It takes some time for the skin to regenerate. All these modalities that are topical like this are also like enlisting your immune system to take care of those cancerous cells. So they, in their own right, can kill some of those abnormal cells, right, by burning them off. But they're also enlisting your immune system in the repair phase of your skin, and that will clear out some other skin.
And it's triggering that to find those specific things.
Right. For people who have multiple actinic keratosis or a lot of sun damage, we can use blue light therapy.
Yes.
And that entails you coming to the office. We put an application of a product on your skin. You sit in the office for a little bit. I know some people do it differently and they give it to the patients to put at home, but I'm more comfortable with my patients sitting there.
It desensitizes the skin, so it's acceptable to that light.
Yeah, so that it can be susceptible to the blue light, and that way it will eliminate, again, signal your immune system to come and clear up the medicine itself, its effects on the cells. I prefer you stay in my office while that medicine sits on you, because then we know it's sitting on there for the appropriate amount of time. And there will be a scaling up on the amount of time that you have that product on your skin to get rid of it. And there's multiple treatments involved. But again, preventive to take care of that damage.
It also helps, like anything that's not getting taken care of without, it needs to biopsy, because it's probably further along.
Right. So I tell my patients, I'll freeze something once. If it's come back, I'm probably going to biopsy it, because we could also have selected, right, for the stronger cells. Like we got rid of the cells that were precancerous and we've selected for stronger cells that are potentially cancerous. So it's okay to do some of these therapies, and we do a lot of it for what looks precancerous, but you don't want to be spraying the same areas over and over and over again.
Yes.
Without seeing much improvement, because that really means you might have a more advanced cancer. So biopsy is never a wrong thing to do if you've failed the cryotherapy,
the blue light,
or the chemotherapy or immunomodulator creams that Andy referenced to that you can do at home. So after that, we're going to go to the in situ cancers.
So we can talk about, again, that'd be something we can definitely use the topical chemotherapy creams on, or we can do something called an EDNC, which is destruction and curettage. And that is where we there's a specific margin around the area that we take. So I usually mark what I can see, mark the margin, we numb the patient up, and what we do is we basically scrape the skin with a curette and burn it. And you do that 3 different times in 3 different directions. And what that's supposed to do is you basically keep scraping the bad cells. Skin cancer scrapes a lot easier than normal skin.
Yes.
And I know there's some MOHS surgeons out there that'll do that prior to even starting their MOHS to see what direction they need to go in. But you'll get to the point where it's just not scraping anymore, and you've gotten to the level you need to be at, and then that area is treated. Yeah.
And I will do that sometimes, but I'm primarily like one of the surgeons in my office. So a lot of those treatments get done by the dermatologist, and I usually get the more invasive cancers. I don't get a lot of the in situ cancers. Mohs surgery, which we'll talk about now, is also adequate for in situ cancers.
Yes.
In situ cancers can be very tricky because they can be microscopically seen under the skin at a much wider range too. It's those little roots, right, that are underneath the skin that you can sometimes not see to the naked eye. But Mohs surgery is a very specialized type of cutaneous surgery, so skin surgery, where a dermatologist is trained not only in detecting skin cancer and in surgically removing it with the scalpel, right?
But reading the pathology
afterwards. So like in our office, I think all of our offices, except for some of the smaller satellite ones, will have a Mohs surgeon. We have a laboratory where we will get the tissue. The Mohs surgeon will go in there, mark what they can visually see, put small margins, because one of the purposes of this is not just to be accurate, but is also to spare as much normal tissue as
procedure.
Yes, exactly. It's a tissue sparing procedure. So we want to spare as much of your normal skin as possible. So they will put a few millimeter margins on there. They will cut around it. They will mark it, and they bread loaf it. So that's looked at in multiple different planes and directions. That tissue gets frozen, it gets stained, and then they'll look at it under a microscope. It takes about 45 minutes between the time the cancer gets removed to the time it gets read by the Mohs surgeon. And then they'll be able to tell if they took out everything or not.
And I tell my patients, the best way to explain it is they read it like a clock. They write it out. If they only see skin cancer left in the 3 o'clock area, that's the only direction that they go back and take more tissue. And they keep repeating that process until it's gone.
Right. So you can come in and you can get it out in 1 round. I've had a patient go 9 rounds one time, or actually, I lied, 7 rounds. It was just 9 centimeters. It was pretty large at the end of it. But that is one of the most accurate ways. It's 99% effective in making sure that all the cancer is removed, which is the best statistics, right? Because nothing is 100% ever in anything in the world, right? There's always a small margin of error in anything that we do in medicine, right? Because we are not God. We are not perfect.
Right.
And, there's always a small amount of error, but it is the best technology that we have on site that we can do a tissue sparing surgery to give you the most adequate diagnosis on the fly.